Dr. Naidoo. I'm now going to hand over to you, and you're going to speak to us this evening about asthma. And I'm just busy opening up your presentation.
Fantastic. So World Asthma Day has been part of World Health Initiatives for many years now. It started with a very, very narrow focus about preventing asthma deaths, and with time has evolved to have more and more ambitious goals, really to foster wellness when it comes to asthma, which is very much a journey that we've had with all chronic health diseases. We've started out with having a very focused look on diabetes, on outcomes, but now we've expanded to these better looks at how can we promote wellness in all of our patients. And the theme this year is particularly relevant to all of us because that is the key. Asthma education is what empowers. It empowers ourselves as healthcare workers to provide the best quality care. It empowers our patients to provide, to be the best partners that they can be in that healthcare process, rather than passive recipients of health. So this is quite an important, it's an important jump from that kind of prescriber mentality to partner in health. And this is why, particularly since I think in the last 5 years, the World Asthma Day themes have become more and more about advocacy and advocacy for better patient participation than what we would have had 10 or 15 years ago, where we very much were championing access to medication or making sure that we had better distribution of essential drugs. So it's been an interesting evolution to watch the last 20 years of World Asthma Days. And it's a point of pride that South Africa has participated enthusiastically in World Asthma Day for basically since So, Madeleine, shall we, when I want to advance, shall I just say next?
There we go.
All right. So my interesting other theme is very topical for me, and I suspect very topical for all of us, is that we are all living under circumstances of financial austerity, which is the very diplomatic way to describe where the Department of Health finds itself. And I think it's quite important for us who practice in the low middle income sphere to make a concerted effort to marry the circumstances that we find ourselves, whether we be tertiary or primary or urban or rural, or well-resourced or low-resourced, with safe practice. So that's the next slide, please. Okay, so this is really what I remember from my community service here. So this is kind of a day of my life, and I called it a day in the life of Dr. Average, because I think this may be a day in your life as well. And the arrows are every place that you can possibly find an asthmatic. So in the ward rounds in the morning, it's a mad rush because you may have 5 patients in the ward, you may have 15. They've come in from intake last night.
Oh, shit. Oh, shit. Sorry, you got muted by mistake, Shirani. Apologies. I'm just... Shirani, sorry, we can't hear you at the moment.
Yeah, I'm here.
There we go. You're back. So just perhaps start again with this slide. Apologies.
No problem.
You
want to go back?
No, it's fine on this slide. Just start again on this slide.
Okay. We're still talking about the previous slide.
Okay. Oh, did I?
Yeah, you skipped on too fast.
Okay, sorry.
I actually just wanted to point out that there's a lot of iffiness in this, because where do all of your jobs fit in? If you're rushing through the ward rounds, whose job is it to teach about asthma devices and do that kind of long-term asthma education? Should it be the ward doctor's job? Because then you go to outpatients afterwards, and sometimes there's 40 or 50 patients waiting to be seen. Do you have a space where you can demonstrate asthma devices? Do you have a space where you can get heights and do peak flow measures? So there's lots of things that impede your effective functioning. When it comes to outpatients. So we've got a message from a Philippe who says there's no sound at all. Can we just do a sound check?
No, I can hear you, Doc.
Yeah, I can
fantastic.
Also hear you. Shane, Philippe, just check your computer.
All right. And there's a very important thing that, we call inertia is quite an important thing, but there's something called clinical inertia, and that's really hard to tell. When you have a doctor who knows what the latest guidelines are, who knows that there's something that needs to be done and just doesn't do it. And why is hard. That person could be burnt out. That person could know what to do and not have access to the facilities. That person could be prevented by many, many of the obstacles that we know are present in our healthcare system, be unable to institute the change they would like to see. But clinical inertia, when it comes to long-term health conditions, is a very real obstacle to changing outcomes. And then you go from outpatients to on-call, where again you sit with 20 to 30 to 40 patients. Asthmatics, they clog up your benches. But there is morbidity and mortality, and South Africa has the unfortunate distinction of being very high in the worldwide mortality stats. We know that infrastructure is difficult. We know consumables are important. We don't always have all the meds that we need. And then you go to the post-call ward round where you are really, really finished. You've been on your feet. And are you really going to do all that you can with that patient that you've admitted 3 or 4 times in the last winter, not taking their pumps, smoking like a chimney? And these are the reasons that we just don't get the outcomes that we need. Madeleine, will you go to the next slide? This slide may not work because it needed my UCT logins to make it work, but it was a form. And there were a few questions that I wanted you to kind of think about and jot down for yourself. Is it going to work? Is it going to work? While we're waiting for this, I'll tell you, friends, I have, in a fit of enthusiasm this year, joined a technology and teaching course to try and make my presentations more IT savvy. This is supposed to be a form, and it's supposed to ask you.
For a sign-in, yes.
No, it's not going to work. Let's just move on. So I'm going to ask you on a piece of paper that you have next to you for yourself. Answer some questions for me. How many asthmatics do you see in your practice? Kind of in 5s, less than 5, more than 5, more than 10. Do you see more of them in the emergency setting and more in the ambulatory setting?
Lady Danbury mentioned the music being fine suitable. So I believe.
Where do you prefer to work? Do you prefer to work in emergency and ambulatory? And if you have an answer, I want you to think about the why, because the why may tell us something about where you feel uncomfortable, where you feel possibly that you don't know as much as you should, where you're finding obstacles. Because I think that place that's uncomfortable for you, maybe we can talk about things a little bit this evening and try and get you to a place where you're more confident. Next slide, please.
I'm just trying to get out of this form now.
Get
Sorry.
out, yeah.
Let me see. Apologies, it might take. I'm trying to escape, but it's not letting me escape. Oh goodness, what was that?
Fantastic. No. All right.
Okay.
So this is actually a new slide, but so I know I told you about Dr. Average, but the bottom line is not every person works under the same circumstances. We'll all need coffee to get through the post-call day, but we know that not everybody is able to prescribe the same meds. We work off very different formularies in different countries and different provinces. We know that time is a very big rate limiting factor nowadays. We know that funds a very huge problem in terms of maintaining our formularies, maintaining our wards, maintaining our equipment and infrastructure. And we know that risk-benefit ratios as the way we practice are very different. If you look at the asthma research all over the world, you see that we in the global south and the low middle income, we're still asking different questions. We're still asking how to keep our patients alive when other people are asking what's the best biological to use. When you are already using fancy agent number 1, what's the benefit of changing fancy agent number 2? So the life of the average doctor dealing with asthmatic patients really is contextual. And that's important for us because we have many challenges that we need to navigate safely, but we also have many strengths that we don't always think about. Next slide, please. It's important to remember that there have been pivotal changes in the international guidelines. I'm going to speak about the international guidelines, the GINA guidelines, because I would like to be a little bit of an agent of change with these webinars. National guidelines have not, the formularies of the Department of Health have not moved with international guidelines. And I really just wanted to put the evidence base out there so that you could be aware of it, and you could individually think about your practices and how you would possibly like to move with the evidence. The big change, and I've put this up here and I'm just going to be blunt, the concept of short-acting bronchodilators used alone is not within the international guidelines. Once you have decided that you have a patient who has got asthma, you initiate inhaled corticosteroid therapy. How is open to variation. You can give inhaled corticosteroids with short-acting bronchodilators on a PRN basis when a patient is symptomatic. You can give ICS regularly, or you can give ICS as part of a LABA combination as a maintenance and reliever therapy. But from GINA, which is the Global Initiative for Asthma Care, from their perspective, they've made a very firm decision that there is no place for short-acting bronchodilators only. Now, for us who've trained in undergraduate programs in South Africa, that was the cornerstone of our education. We all remember that little table where it says short-acting bronchodilators as a trial. And that's what we grew up on. So this is a very big change that's come in asthma management over the last 5 years, since 2019 onwards, where the evolution of the evidence and the reanalysis of the evidence has brought us real concerns about safety. If we can move to the next slide. Okay. So these are the 2 slides that I've used these slides regularly because they really do focus our thoughts about where we practice. So on the right is our mortality. So that's age bands and all-cause mortality. And you see the red arrows right at the bottom. That's where we are as a country. We have excessively high asthma mortality overall. And if you match us against countries with similar population size and similar socioeconomic demographics, there is no reason that we should be seeing as many healthy adults die of asthma as we do in this country. Pediatric mortality has plummeted over the last 2.5 decades, but for our country as a whole, it remains a significant public health issue. If we look at the left, this is just a tiny little snapshot that I have done of the clinics that refer to my hospital. I've stalked them through the pharmacy system, and I can actually see how much they dispense, how much inhaled corticosteroid they dispense versus how much short-acting bronchodilators. And there's a marked mismatch. Our primary healthcare services are dispensing loads of short-acting bronchodilators and a very modest amount of inhaled corticosteroids in comparison to that. And it actually just gives us a snapshot of where we are in this country. We are a nation of people who are not accessing inhaled corticosteroids as regularly as we should. And instead, our population are using short-acting. And the evidence for that is very clear. If you look at the recent studies and the big meta-analyses, not only is it increasing the risk of exacerbations in the short term, it really does increase your risk of asthma. And this is studies that have come out of well-resourced countries. For example, the Fatal Asthma Review in the United Kingdom, when they looked at fatal asthma over long periods of time, they are the patients that you would expect to see on that list. The poorly controlled asthmatics who have severe disease, who need multimodal therapy, who belong to the severe asthma clinics. And those, while tragic, are kind of the patients you expect to see on this kind of list. But a chunk, a good third of those patients who you find in the asthma death review are actually mild asthmatics. They would have called themselves mild asthmatics. Their doctors would have called them mild asthmatics. And the concept of mild asthma and risk stratification is something that's come under increasing scrutiny. Is it a linear relationship between how your doctor classifies you and your risk of severe exacerbations and indeed of death? And more, we're finding that there is not sufficient evidence for us to say, you have mild asthma, you have no risk factors, go along, be happy with your SABA, no harm will come to you. And that has been the pivotal step over which GINA has decided to retract all of their guidelines that have SABA only written anywhere in it. So, Madeleine, if we'll go to the next slide. We can talk a little bit about ambulatory management. Next slide, please. There's a little bit of a question. Madeleine, perhaps we can pick up questions a little bit later. Are you happy with that?
Yes, so please do put your questions in the chat, and then at the end we will go through the question.
So if we look at the GINA treatment algorithms, there's two important things that I want to highlight for you. The little circle at the top is quite important because it's that circle of assess, adjust, and review. The long-term plan with inhaled corticosteroids is always that we are going to use the smallest amount of inhaled corticosteroids that we can to maintain control. So the 2024 GINA guidelines, and these are now updated every year, and there are changes every year, which is quite important compared to maybe 5 or 10 years ago, where they would be every couple of years, there would be a change. So now what they have is they have the preferred tracks that come out due to evolving evidence, a far less complicated treatment algorithm, where the older children are now merging with the adult track, much more homogeneity. Long-acting beta agonist therapy is initiated earlier. Inhaled corticosteroids are contained. Clear guidance for when you need to escalate doses, and earlier referral to specialist service is being built into the GINA guidelines as opposed to increased corticosteroids. Next slide. What is slightly new in this year is that there's more advice given to us. When you start a patient, what is the starting dose that you would need? Previously, you would have to extrapolate what is the degree of symptoms that this patient, would you start them on the low dose of the treatment pathway, would you start them on higher dose? GINA has actually given us a little bit of guidance as to where we start, and thereafter, at each visit, you would then assess control, and then you would try to titrate over time to the lowest dose of inhaled corticosteroids to maintain control. Next slide.
Veronica, we can't hear you.
I'm actually waiting for us to go to the next slide.
Oh gosh, okay. Is that the one that says ambulatory management at the top?
Ambulatory, but this is a summary, so just go forward. Yes. So now we're seeing the problem. Well, let me not say problem. You are seeing the challenge. GINA has advocated strongly against SABA alone therapy since 2019. And this is a copy and paste from the EDL as it stands. So here, these two big documents, GINA, which is the international guideline, which the Respiratory Societies, National Asthma Education Program, the Allergy Society, South African Thoracic Society, that is the body to which we look to for our guidance when it comes to the evidence. Definitely the pediatric guidelines, very much the national guidelines from the kind of the academic circles have very much followed them. And now we set up as clinicians in this very uncomfortable position where the EDL, which is our functional guide in our clinical spaces as employees of the Department of Health, these two things are in such stark contrast to each other. Because on the one hand, the EDL has entrenched this concept of infrequent asthma, which is really analogous to mild asthma. It's dug into its heels about SABAs being suitable to be used up to 3 to 4 times daily with an MDI. And just to kind of remind yourself how symptomatic this allows you to be, you can actually be using multiple doses of short-acting bronchodilators without it flagging on the EDL as a patient with poor control. So this is a point of conflict that has not yet been resolved. We know that all the members of the EDL committees are lobbying for this to be changed, but it's a thing that puts us as clinicians in quite a difficult space as to how do you move forward with the evidence when the formulary is tying you to the SABA only treatment pathway. Madeleine, next slide. The persistent asthma, you see here again, entrenches this concept of mild persistent, moderate persistent, severe persistent. And if we look at the referral pathways, it's quite vague as to what it means as unstable or difficult to control asthma, or when asthma interferes with normal life despite treatment. We'll go to the next slide, Madeleine. So I wanted to not focus on the nitty-gritty of management, but really think about what are the things that we can be creative about, and how are the things that we can try and be safe when resources are tight. What is out of all our control is the national formulary. But it is always possible that you might, at a local level, be able to motivate with your pharmacy for different medication routes for certain patients. We can always try to make sure that we have our base clinical care, that you really do focus on tight assessment of control and use any adjuncts that you have for risk stratification. So when I talk about adjuncts, I'm talking about things like asthma diaries, which you download from the respiratory societies. I'm talking about peak flow meters, which you use in lung functions, so that you can correlate your clinical finding, your assessment of symptoms from the patient with your lung functions. All of these are within even low resource areas, urban or rural. Specialist referral is entrenched in the referral pathways, but we know that the referral networks are stretched. Perhaps you might not be able to always get your patients physically to a referral center, but a good relationship with your district, with your tertiary, with your regional services may be able to bridge those problems with physical referral. Good telephone communication, email communication, medicine, however you'd like to practice. We know that asthma, like many pediatrics, has a surge season. Surge season is traditionally what we refer to as that mixture of respiratory viruses and gastroenteritis, which happens at this time of the year. But asthma's got a similar pattern. There are times in the year where you have more. So audit your local exacerbation pattern. See when your patients present. Who are the patients who present? Hold on a second.
Shirani, I think you were muted
I
again.
muted you for 2 seconds. I'm at work and there was a very loud emergency call over the intercom. So there is a red box somewhere in our hospital. I muted you quietly so you all didn't have to panic as well. So I was talking about the referral network, third season. why I say that audit is, just 1 second, it's also very loud outside. I'm so sorry. I chose to join from work because I thought it would be quieter, and it's turned out not to be quieter. The reason that I am encouraging an audit is quite an important thing. If you look at the critical care ICU admissions, they are large tertiary service, but they have a small population of patients who regularly present in extremis. If you look at Red Cross as well, within our big asthma population, we have a certain frequent flyer population. So if you audit your local exacerbation pattern and you can identify who your at-risk patients are, it's easier for you then to be proactive and intentional about third season planning. This means making sure that you bring those patients in for a pre-seasoned assessment. Make sure that you have checked that they are not out of that the inhaled corticosteroids prescriptions are filled. Influenza vaccinations, talk to them about action plans. How are you going to access emergency care in case of exacerbations? These are all ways to take your asthma management from just a kind of a tick sheet EDL type format into being more intentional and more precise about matching the needs of your patient to your actual care. And this is the last important thing I'm going to say about ambulatory care. Holistic preventative care is the most cost-effective emergency management. We spend enormous amounts of energy in our ECs in managing acute exacerbations, where we really should be focusing that energy on preventative care. But what's not in our control as practitioners is that outcomes only change when the behavior of the patient changes. It's not just prescriptions. So as much as we need to focus our thought on assessments of control, making sure that we have the correct medication package for that, it's the whole being that we need to think about. What are the factors that are driving the behavior? If there's poor adherence, why is there poor adherence? Is there a system block that we can find out? Is there a problem at pharmacy? Is it with the refills? Is it the family taking time off work? Is there a way that we can streamline our part of patient behavior? And there are often many access blocks that the Department of Health can assist with. Are there external factors in the rural community? Seasonal factors, for example, is there pesticides that might be triggering asthma exacerbations? Is there harvesting that might be? For example, there are many molds from stored grains that can be a potent trigger of an asthma exacerbation. So this kind of auditing, intentionality about your prescribing and your practicing, and holistic medicine is quite important. It's important for anyone, but it's most important for the clinicians who have small amounts of resources and need to make every penny work for them. Madeleine, will you move to the next slide? Okay. The next thing I just really want to talk a little bit about is emergency management. So here, I have no real issues with any of, I'm going to highlight the EDL, and then I'm going to show you the Red Cross algorithm, because they have no real conflict. They are laid out in different ways. One is a table, and one is an algorithm. So if tables and more writing is what you like, then this is the way to go. The EDL is very useful because it gives you quite nice parameters as to where you need to plug your patient into. We have the mild exacerbation stream, the moderate, and the severe. And under each category, they give you quite nice detailed information as to how. Things to remember about this. The hard research about asthma exacerbations is actually very minimal. If you go out and survey the literature, you'll find that there is not that much out there. Much of what we do is what we have learned from our consultants and what they have learned from their consultants. So the evidence base is not the strongest. If you look at the South African population, our morbidity and mortality comes from two major things. One is the health system. We know that more patients die after hours, and more patients die on the weekends, and more patients die out of facilities or on their way to facilities. So our health network and our infrastructure is really, really important in our outcomes. The other reason that people die is because they are under-assessed. The initial assessment is not detailed enough, and it's not followed up by sequential examinations. And this under-assessment or under-appreciation of severity is quite important. So the most important thing I want to say about this slide is that a failure to improve as expected is as important as any of these other issues. And I say this not to judge you, not to preach to you, but to tell you that this is something that happened yesterday morning in my unit, where we had a little person coming in who really was sitting up and talking, and really for all the world looked like a moderate exacerbation, but was just refractory. So rapid assessment with frequent cycles of reassessment is the most important part of managing an exacerbation. We'll go to the next slide. This is a very facility-specific protocol. It's the one that we use in the Western Cape, and I highlight it not to advocate it above others, but to highlight another important thing. It's important to make sure that all parties play the same game. The overwhelming advantage of this protocol above others in our setting is that all of the facilities that drain to our hospital have actually had us sit down. We've all agreed that we are going to use this. Our emergency transport system, EMS, is also on board. So when COVID came, we had a departmental meeting. We had a single protocol. We all speak the same language. So if you are at our hospital or a referral hospital or a district hospital, and you call and say, I'm going down the severe asthma algorithm and I'm doing X, we're all on the same page. So continuity and standardization of care is really, really important when you are in a referral network, because it helps the referring doctor understand where you're at, and it helps the accepting doctor know where you are in the treatment algorithms. Next slide, please. So there's a few things I wanted to say about emergency care. So we know that emergency care is a right for patients, but it's not always a reality that patients can achieve and access. When it comes to asthma, hypoxia is what kills patients. In our learning, we always think about hypocarbia and the respiratory acidosis that you must be wary about. But it's actually hypoxia that is the driver of mortality. The other thing that can be done early and can be done at any level of care, is the systemic steroids. Now, I said prednisone deliberetely because overwhelmingly, that is what patients can tolerate. There's a very small amount of patients who are so short of breath that they cannot swallow, or who are so nauseous that they cannot tolerate oral prednisone. It is absolutely far cheaper. It's easier to give, and for the system and for the evidence, it's definitely the one that we would recommend. Now, when you talk about exacerbations, if you've been at a talk that I've given before, you know I like my silly memes and I like my silly pictures. So when it comes to acute asthma, I really do think there's two faces that you've got to think about. Call it the fast and the furious is the one. This is the patient who presents in terrible distress, who responds beautifully to short-acting bronchodilators. We often think about that as the face of asthma. But just cast your mind back to the physiology. We have two components when you have bronchospasm. We have the smooth muscle, which contracts and gives you acute symptoms. Definitely, that's the one component. But when it comes to asthma, we have the airway edema That is the symptom of long-term inflammation that has been brewing slowly in sometimes for weeks, sometimes for months. So when you have a patient who comes in with predominantly bronchospasms mediated by the muscles around the airway, that is the patient who's got plentiful activation of the short-acting bronchoreceptors, who's going to respond to your SABAs, who's going to do well. This is the classic kind of person who comes into the EC, very short of breath, hypoxic, is intubated, and does well. And there is a category like that, but they are the smaller category. The bigger category is the patient who presents slowly, who's been symptomatic at home, who now has increasing airway obstruction due to edema, and this is the patient to be aware of. They do extremely badly, where the person, the fast and the furious, may be challenging to intubate, but will respond well. This is the patient who really have to be worried about, because they are the one who's going to be hard to ventilate and is going to have a significant challenge in their ICU stay. So remember, everyone is to be always to be wary of acute severe asthma, but it is the patient with that slowly unfolding exacerbation that you really must be worried about. I've spoken already about repeated cycles of assessment, but without delaying treatment. When I look at my unit, I often see that people will faff about. They will try and get the X-ray done. They will want to do bloods while they are delaying treatment. So make sure that you get going, you do your cycles of assessment and initiation of therapy similarly at the same time. I've already alluded to the poor evidence base that we have for most of our intervention in acute severe asthma. But what we can say is the more severe the exacerbation, the better the evidence is for multimodal therapy. When I say multimodal therapy, I mean don't use the same thing again and again and again. If something is a SABA, don't use a SABA in a different form, and a different form, and a different form. Most of the algorithms, if you follow them up, will have an opportunity for you to use another drug that will give you bronchodilation in a slightly different way, so that those two drugs can work in a synergistic fashion. As an example, the evidence is very strong for moderate to severe exacerbations that ipratropium bromide has a positive effect. It works beautifully in combination with a short-acting bronchodilator because those two actions are synergistic. And from there on, we escalate and escalate and escalate. As we progress down the algorithms, we go from drugs with very minimal side effects to drugs with a more challenging side effect profile. So when you're moving down a protocol, think not only about the patient and the medication, also think about your context. How are you going to monitor that medication so that it's correctly administered and safely administered? The algorithms, international algorithms, and the evidence will put the salbutamol load, as slightly higher on the evidence chain than magnesium sulfate. And in our metro, we definitely use it in the other way around. Very practical reasons, because the dosing, administration, and post-administration monitoring of magnesium sulfate is much easier. If you're at a district hospital, to ask you to give MagSulf is much easier, and if you are EMS, to transport that patient is much easier. So if you're going to use salbutamol, make sure that you have checked the dosage and that your administration is correct. And remember, once you start using salbutamol, and particularly if you are going to be using the methylxanthines, then cardiac monitoring becomes important. Intubation and ventilation in an asthmatic can absolutely be challenging. I don't say it as a reason for you not to do it if the patient's clinical picture warrants it. But do remember, if you're going to intubate an asthmatic, you need the best hands on site, and you need to be making urgent plans to getting that patient to tertiary care, and you need to be initiating that discussion about the patient from minute one. In our setting, we have very much adopted non-invasive ventilation for the management of acute severe exacerbations. There's a fair amount in the literature about the pathophysiology of why that works. And certainly it's been our practical experience that it's been very, very useful. And while we complain a lot about practicing when resources are tight, it's quite fair to say that there is no cloud without a silver lining. The one overwhelming benefit of the COVID pandemic is that we realized that we function very, very well without nebulizers. You will remember that because of the risk of healthcare workers, we looked very hard at which of our treatment initiatives actually would increase risk of COVID transmission within our emergency centers. We definitely took a very hard line that it's only life-threatening asthma that would be nebulized with anything. Obviously, croup is something different. And we discovered at the end of the pandemic that we actually didn't miss those nebulizers at all. They haven't made their way back into the treatment algorithm, and I don't think they're going to, because their role in the management of exacerbations has really, I think we have placed too much emphasis on it through the years. If you think about how nebulizers work, they generate large size particles. The disease of asthma is a condition of small airways. And there's a really good, a lot of people who go that we should never have been using them as much as we did. The management of asthma via an MDI and a spacer and a mask, depending on which is appropriate, is absolutely appropriate. And that was, I know it was a difficult time, but that was one resource constraint that we actually have benefited from enormously. Next slide. Okay, so this is on that same theme of looking for opportunities where we actually can see what can we work with, what do we have to work with, and what can we do for us. There are very many challenges in the low middle income setting. So access to medication and appropriate devices, despite being on the EDL, is not always possible. Patient education in a multilingual, multicultural country can be challenging. Even things like quality of life and fear of losing your job and stigma was still present in all of our communities. Healthcare worker training is an ongoing challenge. We know that research and policy recommendations are at the moment in our country slightly at opposing sides. We have research that suggests that SABA use alone is not good, and we still have it entrenched in our EDL. And we know that the actual geography of our country sometimes is against us. We are a large country with large districts, and patients need to be transported over these areas, sometimes with very limited emergency medicine support. So if we look at it the other way, just if we look at our opportunities, telemedicine and technology, these are things that increasingly we are embracing. We are having a webinar now with participants in many different countries, and information can be shared and clinical support can be provided from many different centers. When you are working in a smaller town and a smaller facility, community integration often is easier than when you work in a metro with many millions of people. And similarly, when you work in a small district, intersectoral collaboration can be established. It's not just the Department of Health. The Department of Health can integrate with the schools, with the churches, with the soccer teams. So that small team nature, particularly of rural medicine, can be an advantage as well. Both of these advantages and disadvantages both converge on an action plan, which is what I wanted to speak about this evening as a possible way for you to marry ambulatory and emergency care and try to make it slightly more holistic and become a patient-held record. So if you can go to the next slide. An action plan is very analogous to the Road to Health card, except that it is tailored to the patient with asthma. It is a very specific thing in that you tailor it to your patient, to your context, to what facilities are open when, what is your emergency transport, what is your patient's particular level of control, what is their baseline, and what is their pattern of exacerbations. And this is something that you can download from the National Asthma Education Program. The Allergy Foundation has a similar one. And it's really quite a useful milestone in this journey of asthma education and patient empowerment. So early in your treatment pathway with your patient, soon after you've done diagnosis, kind of discussing the diagnosis with the patient, initiating your long-term therapy plan, at some point you're going to have to discuss exacerbations. How is your patient going to access care? When are they going to know that they're having an exacerbation? What can be done at home? What needs to be done via the medical services? And when that patient needs to urgently seek medical help. Now, this is quite useful, particularly for the rural setting, where you can give quite detailed information. It can be tailored to your aspect, to your particular services. It can be tailored to which of your services are open 24 hours. Is it only the hospital? Which of the CHCs are available? And it allows you to, in a quite directed fashion, make sure that a new clinician who sees your patient for the first time actually gets an immediate snapshot of what they are like. You can build in basic medication, their regular controller therapy. You can add in what their lung functions are, what their best peak flow is. You can add in a few comments about what their previous exacerbation was. So it's a very nice adjunct to the Road to Health card, in that it allows the patient to become an empowered partner in treatment, but it also tries to bring the EC doctor and the ambulatory doctor, who might not always be the same people, closer together. Because it's an adjunct to the Road to Health card, the long-term health care plan can be jotted down, how much inhaled corticosteroids, etc., and the EC service can then add a few comments about the latest exacerbation. It's very useful in getting an idea of how frequently the patient exacerbates, and it's also very, very useful in tracking how often patients are using rescue oral steroids, because that is a little bit of the absent partner in all of this. We've spoken about inhaled corticosteroids. We've spoken about maintaining a low dose of inhaled corticosteroids. But the thing that slips through is that rescue oral steroid course, which should be 2 milligrams per kilogram or 40 milligrams for 3 to 5 days. We are trying to keep it at 3 days, shorter bursts rather than longer bursts. But it's very easy for that to slip through the net, and for you to find a patient who then has systemic steroid complications, not inhaled corticosteroid, but from repeated prescriptions of rescue steroids. Next slide. So, asthma plan, it's safe, it's cheap. Risk stratification can be challenging, but over time you can get an idea of what of each patient is. You can customize it for your patient and their comorbidities. You can customize it for your content, for your context, and for the particular triggers in your area. And we've alluded to some of the things that might be specific to the rural population. If it's a patient frequent exacerbations, you may even need to develop an emergency pack. I know I've spoken with certain concerns about the emergency steroid pack, which some people use, but it's unmonitored systemic steroid use that is the risk, not the systemic steroid in and of itself. Be consistent. An action plan coupled with an asthma diary really helps you to understand how frequently your patient is symptomatic, and with that improved understanding, it really will help you with your referral, because that will be the next step up. If you're able to achieve control, when you refer on, your referral hospital will want to see what measures you've taken to with your patient thus far. The asthma action plan marries very nicely with other patient-held documents like pamphlets, directing patients towards media clips, social media clips, websites, and it becomes one block in that puzzle of creating an empowered patient. And it really feeds into where I started, whereas improved outcomes come in behavior shifts. This is one of those quite nifty little tools that you can use in your journey with not just a patient, but a patient and their family. Next slide, please. How to amplify education. I'm not seeing the challenges. There are huge challenges that we find in our centers, tertiary, regional district, but really it does start with you. And wherever you can find and create an opportunity to have a partnership or to amplify education, that's fantastic. This year, for example, the World Asthma Day project that the National Asthma Education Program that we ran is finding some way where we could share resources more easily. We used to many moons ago have paper pamphlets, and I actually can't remember the last one asked us to print out pamphlets. Paper things are just going out of fashion. So we've embarked on a partnership with a local an app, EM Guidance, where they've figured out a way for us where we can share our pamphlets with other healthcare workers, and healthcare workers can that's with their patients in an anonymous way. Now, obviously, I had to get instructions from the EM Guidance because you've already seen how good I am with the tech. But this in itself represents a partnership that we've gone out and created. So within your sector where you are working, what are the opportunities that you can find? Perhaps, is there a local primary school or high school that you can partner with? Is there a library that you can partner with? Are there civil societies? Are there swimming schools or the rugby school or the local church? What are the opportunities for you to amplify education at maybe next World Asthma Day? It's not me speaking to you, but it's you being invited to the local primary school or the soccer club to speak to their young clientele about how to diagnose asthma and how to manage their own asthma. So it's this concept of each of us moving on kind of in a little tree, educating at each turn and improving kind of our health partnerships. Next slide, please. This was a point at which I thought we were going to pause, but we are already at 6:30. It's also a place where we can stop to take questions. I had 2 other slides on the management of the under 5, but Madeleine, I'm quite happy to leave them and focus on questions instead.
Well, let's just see what's in the chat in terms of questions. And there's that one from earlier on, wondering, yes, about the issue of access to ICS or LABA, and what do we do if we only have SABA and oral cortico steroid, for example. I don't know the pediatric ones at all. I know the GINA adult ones, we have that option to either use the turbohalers or to use the combination of ICS and SABAs, and maybe you can just speak to that. I do wonder though, in terms of, can we use the combinations that we are using for adults? Is it the same preparations that we are using for children? Because those are broadly available at most places in the public sector.
I'm just going to go and I'm just going to go back to that question. Where is it that we only have SABA and oral corticosteroids? Because that should be nowhere where the EDL is. The EDL and prescriptive about when we can use LABAs. But and if we can go back to that EDL, there definitely is a space for that. If we can go back, Madeleine.
Yeah. Sorry. This one, EDL2. Yeah,
EDL2. So there definitely is a space for us to use LABAs. The LABAs, and nicely spotted, these are salmeterol, which is not the same as formoterol. And the formoterol prescriptions are the ones that we use as maintenance and relievers. but they definitely are larvae. So while we are stuck with the formulary, there are options, and there's nothing that stops you from auditing your patient, seeing how often they present. Remember, emergency care is not cheap. Auditing a year, saying there were 3, there were 4 emergency admissions, there were 2 hospital admissions, there were multiple visits to the clinic, and putting that to your local version of your PTC. I mean, most facilities will have some kind of oversight over prescriptions and doing a cost analysis, because how expensive are asthma exacerbations? I can tell you, very expensive. How much does it cost a facility and a system? So these are the kinds of things that I meant when I said audit. If you have a patient who is presenting frequently with poor control, motivate that he is in fact a moderate persistent asthma and needs that LABA. Remember that the LABAs are registered in children at different ages, but it tends to be 4 and above. So I'm not advocating to willy-nilly use, but we're talking about children about 6. And so they're part of the EDL, but I'm just advocating that you think about how we use them. And my particular bugbear is SABA only. Adis, is that a suitable answer? Do you have any further questions or any follow-on comments that you wanted to make? If you truly only have SABAs and oral corticosteroids and your facility is failing you, they are not maintaining their responsibilities according to the EDL, and you must take that up with your facility manager.
Thank you, Shirani. And then there's a question here from Tokozo in terms of the preference in terms of ventilator modes for severe acute asthmatic exacerbations requiring tracheal intubation. So particularly from a casualty setting, if you've got any tips on that.
And Tokozo, I'm going to be honest with you. I reviewed our asthmatic patients several years ago. That was in 2013. We'd intubated 1, and I don't think we've intubated any since. So the amount of intubation
the non-invasive ventilation is your main. And what
are
you
using? We use. The thing is, you can either use CPAP or EVO. So unfortunately, CPAP is mostly younger children, and the population that we are talking about is older children. So we use EVO circuits. There's a pediatric and an adult setting, and depending on how big your patient is, they may need the adult setting. And we start at 2 liters per kilo.
Right, that's very helpful.
Very well tolerated. Look, it's not cheap, hey? Those circuits are $2,000 a pop. Mm-hmm. So there is a certain consumable cost that is not insignificant, but for us, we manage non-invasive support in our high care wards as opposed to the ICU. So for us, that's the give and the take. What we've had to do is we've had to do broad scale training for nurses and doctors to manage that. And we've spent a lot of time training up our staff to use it. But now that we are at a place where most staff know how to use it, the cost of not going to ICU has been so beneficial. Because that was the give and the take. What were we going to spend our money on?
Great. And then there's a question from Zambia, Elisina from Zambia, where they sometimes don't have salbutamol. She's particularly talking about NEBs here. I don't know if she means the NEBs or the MDIs in a 2-year-old. And asking for advice on that. You already spoke a little bit about the nebulizers earlier.
Yes, we've moved over to MDIs, and it is far cheaper for us. The consumables are much less. And to be honest, the management of a nebulizer system, you need to be cleaning it so that that reservoir well doesn't become dirty or contaminated. And in the casualty setting, when you have a set of 3 children all being nebulized, screaming their heads off, they actually just set each other off. And the forced expiration of asthma with the forced expiration of the screaming, you actually wonder how much of that salbutamol gets in. What I must say is if you're going to abandon nebulization for meter-dose inhaler, you have to use a multi-dose regimen. So there is no earthly point in giving anyone who is an extremist or having an exacerbation 2 puffs. So we're looking at 8 to 10 puffs repeated every 15 minutes. you have to give big doses to get anywhere.
And then of course,
Sublingual MDIs they are very cost effective. The question then becomes the spacer device, but spacer devices can be reused and cleaned. And then the second question is about a mask. Do not be tempted to cheap out on this. If you don't have a good interface between the mouth and the device, or the face and the device, you aren't going to get good drug deposition. So the hospital pharmacy is going to look at you when you talk about the mask, but this is worth it. A good fit is really, really important. The nebulizer can go, the MDI is not expensive, the spacer can be reused, and in fact, the spacer can be made. You can make a bottle spacer. And I know we used to use them from Coke bottles here at Red Cross, but you can't skimp on the mask for a 2-year-old. Anyone 4 to 5-ish, depending on the developmental status of the child, can be trained to use an MDI with a spacer alone. As long as they can pass their lips around the mouth of your spacer, you are fine. Okay, so that was the last question that I saw in Zambia.
It's one little question that's it's just
the role of budesonide
for Metrorol. I must say in our setting, so I'm in the Eastern Cape at our regional hospital. We do have budesonide for Metrorol on the formulary, and we have it available for our adult patients, definitely. And then in the clinics, if they don't have the budesonide for Metrorol, they've got the salmeterol fluticasone combinations. But I don't know if you have anything to add on that in terms of cost comparisons, Shirani. Shirani, can you hear us? I'm wondering if we've lost her on the one device. I'm sure she's going to log in a moment just to say goodbye. What I think we will do is we will finish this presentation here this evening. What we will do is when we post the material on YouTube, we'll post the video on YouTube, and then we will put links to a Google folder with various resources. So Shirani will send us that action plan, for example, and other useful resources, maybe even some of the algorithms that you might want to be using or applying in your own facility. I'm hoping she's going to join us so we could at least thank her. I think she's still watching us and can hear us, but she can't speak. So Shirani, I hope you can hear us. A huge thank you for this presentation. You can really feel you're on this is a presentation that's literally about saving children's lives. And quite often we have very few but very simple tools available to us. And I think it's part of this thing of being able to really build a relationship with that child and that family and getting our action plans in place to actually avoid those very difficult exacerbations within your emergency room. We want to get to the point where the children don't end up needing us on that level at all. I don't see any other final hands, so I think I'm going to make a unilateral decision here that we can close the meeting at this point. We will post it all on YouTube. There will be another webinar in June, and we will send you the messages for that, the adverts for that in terms of what it's going to be and what's going to happen. If you haven't yet, please put your MP number and your name in our chat. I'll leave it open for a couple of minutes to do that. We were going to run a poll, but our poll button is not working, so it will just have to be, and we'll make a plan. So thank you very much, everybody, and have a lovely evening.